You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is Dr. Aahd Kubbara. We're going to look at pharmacogenomics and pulmonary fibrosis, how to improve lung function, what targeted biological therapies there are for asthma. Myself, of having asthma for 42 years at least. Hopefully this will be literally a breath of fresh air, unintended. So welcome, Aahd. Thank you for coming.
Thank you very much for inviting me.
Yeah, so as a, it says you're a pulmonologist and intensivist at University of Minnesota. So when it comes to asthma, is your work more research or is it more clinical? Like what do you do most of the time?
Yes, I would like to start with a disclaimer that the views expressed in this interview are my own and do not represent the official position or policies of the University of Minnesota or any affiliated institutions. And to answer your question, yes, I do treat asthma in the clinic and sometimes in the inpatient setting, as well as idiopathic pulmonary fibrosis, the other disease we're talking about. I am more involved with idiopathic pulmonary fibrosis, but definitely with both diseases. For research, or on the research side, I do more research with IPF and the bigger umbrella of interstitial lung diseases, which are inflammatory diseases that lead to lung scarring.
Okay. Does asthma do that over time? Like what are the consequences of either treated or untreated asthma over decades?
That's a very good question. In essence, untreated asthma can go on for years and decades in some patients where they're more accustomed to the chronic symptoms. So in other words, they're working around their cough, they're working around the shortness of breath, and they get used to it as if it's like, their norm. And personally, I was one of those patients back in my 20s until I was placed on inhalers, and all of a sudden I felt I can walk a further distance and things seem to be easier. So what happens when sometimes people, normalize their chronic symptoms, specifically in asthma, decade after decade, they do start to lose some lung function that we can measure in the pulmonary function lab. And they eventually become more symptomatic. They start to become more short-winded, doing less activity, and they basically, become more chronically disabled eventually.
Right. So what about the use of, I know there's like short-term beta agonists, long-term. So there's like the rescue inhaler, albuterol is one of the big commercial names. And then there's the ones that are preventative, like Dulera and Advair. So what's been your experience with controlling asthma? Is the short-term better, the long-term, a combination?
Yeah, so we classify asthma according to severity. So in some mild cases, the short-acting and rescue inhaler will be sufficient. So we told the patient, if you have your asthma symptoms, the cough or the wheeze is coming up, you take 2 puffs of the short-acting beta agonist or the rescue inhaler, and you should be good with your day. And often these patients, they only need it once in a while, a couple of times a month. If the asthma is more uncontrolled or more advanced, where they are reaching to that rescue inhaler like multiple times per week, that's where we need a long-acting inhaler, as you mentioned, some of those. So those are scheduled inhalers, and I tell my patients, you're going to take them whether you're having a good day or not so good of a day. So they will take, for example, whether it's a long-acting steroid combined with a long-acting beta agonist. They wake up in the morning, they take 2 puffs, for example, and then they take 2 puffs in the evening, and that becomes a long-term inhaler. And for some patients, like if they get confused about that and the rescue inhaler, I tell them this is like a blood pressure pill. So you have to take it every day all the way until we follow up next time and see how things are, and maybe we can take you off in the future. So this is for more moderate or more advanced asthma where they have to be on inhalers, and sometimes there are multiple inhalers they need to take if the asthma is less controlled.
So if someone's not controlled, even using these, Advair, Dulera, and a rescue, then what?
Yeah, so in that case, we start revisiting like, what are we missing? And that's something we should have asked in the first visit with our patients, but sometimes we don't catch some of the triggers that might still be in the house. house or in their work environment? Is there smoke exposure? There has to be something that, makes the asthma difficult to control. Typically, asthma on 1 to 2 inhalers should be controlled in most cases if we're controlling everything, around the patient and the environment, and realizing sometimes that's not realistic. So the next thing we would look at, we would reconfirm the diagnosis. Is this truly asthma, or is there something else in the background? And sometimes there's a coexisting diagnosis that can be driving the asthma, making it difficult to control, most notably acid reflux. So when the acid reflux is from the esophagus into the lungs, it can trigger a cough and it can trigger bronchospasm, where the airways will tighten up and the patient will become short of breath. And as you would expect, that will make the inhalers not work so well because there's already something in the lungs that is irritating them. That's just an example of one of the triggers for difficult to control asthma. If we square out everything, we make sure that these triggers are controlled or eliminated. We make sure that the patient is using the inhaler in the correct method. Then we explore using a biological therapy, what we call.
So what happens with long-term use? They use seen clinically with like Dulera, Advair, albuterol, that kind of stuff.
There are definitely side effects. Patients can accumulate the steroids over decades because this is a very small dose of steroid in these inhalers. So there has been reports and research showing that patients can develop down the line like osteoporosis. That's brittle bones or weak bones in other terms. And also it can predispose the patient for recurrent sore throat or throat infection, and also oral candida or fungal infection in the back of the mouth. So these are some side effects we see with long-term use of these inhalers.
Anything else, or does it cause pulmonary fibrosis or any of those other problems?
Yeah, pulmonary fibrosis is an independent, separate disease entity. Typically does not coexist with asthma. Pulmonary fibrosis in the context of IPF, which is the most common fibrotic disease, it stands for idiopathic pulmonary fibrosis, is a disease of scarring of the lungs of unknown cause. And the lungs would scar in a certain pattern that is recognizable on CT scan or chest imaging, and follows a specific or more known and predictable trajectory of illness progression. So it's a separate disease than asthma.
Okay. Why do people get pulmonary fibrosis? What are the symptoms?
So the pulmonary fibrosis, in the context of IPF specifically, we were not able as of yet to figure out a specific causative etiology for this disease, but we know of some predisposing factors. Smoking is a risk factor. Advanced age, typically beyond the age of 60 up to 70, that's where we see IPF the most. And also male sex has slight predominance for this disease. And typically when we want to diagnose it and we see that pattern on the chest imaging and we take the history, we try to be as careful as possible in eliminating any trigger or known trigger for lung scarring. Because once we identify a trigger, that's going to remove the IPF diagnosis from the patient. That means that we have, for example, asbestos-induced pulmonary fibrosis, or more commonly these days is hypersensitivity pneumonitis, big term. Basically, it's a type of reaction to an environmental trigger that happens in the lungs and leads to lung scarring. So once we identify a pointer that is linked to lung scarring, we're not giving the patient an IPF diagnosis. We will give them a pulmonary fibrosis secondary to X, Y, and Z. There are so many triggers and medical conditions that can cause pulmonary fibrosis.
Oh, what if, let's say you're allergic to dogs or cats and, you live with them and maybe you feel okay? Could it still be affecting you? Let's say if it did in the past, maybe it's subclinical, or there's no symptomology, but stuff is happening to you. Is that a possibility?
Yeah, that's definitely, it takes us back to the context of asthma. Cats are a well-known trigger for atopic asthma, and asthma gets a little bit more complicated because we're learning different types of asthma. The classic, or more, it's not termed classic in medical literature, but the asthma that we are more familiar with and most people are hear of is the atopic asthma, which cats are a well-known trigger and for asthma exacerbation and making asthma difficult to control. In addition to house dust mites, in addition to pollens and seasonal change, these are all clues, if they correlate with patient symptoms, that this is atopic asthma specifically. And to answer your question, like, can somebody be living with a cat and being asthmatic and being minimally symptomatic or asymptomatic? It is possible. Some asthmatic patients don't react to cats. They react to other things, for example, cold air. So unless the patient is able to correlate that every time they go back home from work or from school and they start coughing, they start sneezing, they feel their chest is tight around the cat, that basically gives me a very strong clue that the cat allergen is driving a big part of the asthma.
Are there any other interesting patterns you see, like someone only at night they get asthma, or they wake up with it only, but they don't have it any other time, or any other triggers that are unusual like that?
Indeed. Nighttime is known for more asthma symptoms in some individuals, and asthma can be, when it's less controlled or when it's more advanced, it can be more pronounced at night. So one of the questions we ask our patients to assess asthma control: do you wake up at night looking for your inhaler, reaching for your inhaler, or wheezing and coughing? And if the answer is yes, that's almost a red flag that the asthma is far from control. They should not be waking up at night looking for the inhaler. That means they're way behind on their medication dosage, or they're not on the right medications. Also, very possible that there's a very strong trigger going on in their household that is not eliminated.
What about if someone has sleep apnea? I would think that'll be a horrible combination with asthma, even if it's old.
Indeed, and sleep apnea would be a horrible combination with any lung disease, so let alone asthma. So in sleep apnea, the combination can predispose patients to acid reflux during nighttime. As patients with sleep apnea, they gasp for air. Sometimes they don't even realize that happening, and that can create some negative pressure, sucking out stomach contents into the esophagus and up all the way to the upper airway, which can drip into the vocal cords, the voice box, and go into the lungs, making asthma more difficult to control, making sleep interrupted, and making medications less effective.
Okay. The act of having asthma and coughing and wheezing, and does that hurt the lungs? Does that strain them over years and scar them?
Very good question that I hear a lot from my patients. The short answer is no. The coughing itself is not known to damage the lung tissue. However, there are definitely some problems that can happen from excessive coughing over long periods of time. One of them that we see sometimes is rib fractures, and that happens more in the acute cough phase. If you have a cough that is very strong over a week or two.
These are you could fracture a rib if you have a strong cough for over a week, but what will happen then?
Yeah, and it can happen over a few days or more than a week, so sometime in that vicinity. The other damage that we are concerned about, which is pretty rare, but they can be damage to the airways themselves. So the branches of the windpipe, the bronchi, probably seen a couple of times a bronchial fracture of the cartilage itself. But I would say that's extremely rare.
But when you cough, wouldn't you pressurize all the lung tissue itself, even the alveoli? Like, could you blow out with hard coughing? Couldn't you blow out some of the more sensitive areas of the tissue? Or if it gets repetitive mechanical strain because of the pressures, like that, might it harden your lungs over time or make them fibrotic? Or
not fibrotic per se, but yes, it can cause a puncture in the lung, which we call a pneumothorax. If the lung is diseased to start with certain diseases, one we call cystic lung diseases, where the lung forms some cysts due to a disease process, or emphysema, which happens after long-term smoking. Excessive cough in these situations can increase the pressure in the diseased alveoli and cause them to rupture. But normal alveoli can take a lot of pressure and a lot of cough without rupturing.
What about people, seems like it's getting more prevalent, never smokers or non-smokers that get lung cancer? Have you looked at like the histology and the pathology of it to see like what's happening in the lungs and why this is occurring?
Yeah, I'm not very focused or deep into lung cancer, but definitely there's more recognition of lung cancer in non-smokers. There are some genetic risk factors related to that. Secondhand smoking is something we used to overlook, and we're looking into it more and more now. So a lot of the non-smokers who have lung cancer might have had significant secondhand smoking, and maybe that contributed to the risk. But certainly we have seen lung cancer in patients who don't even have secondhand smoking. So there's still like occupational risk factors we need to investigate. And as I mentioned, there's some genetics risk factor that predispose them.
What about vaping? I would bet that, I guess whether you know it or not, probably a percentage of your patients vape. I don't know if they tell you, or maybe they're exposed to it. Someone else in the house does, or at work, just people vaping. Anything that's you're seeing out there with people that are in or around or using vaping?
Yeah. So certainly it's one of the things that we started to ask about before we even learned much about what it does exactly in the lungs. And we have identified some lung diseases and problems to vaping, including E-Valley, which is electronic vaping associated lung injury. Very rare disease, but it can get the patient very sick. Correlation between vaping and lung cancer, to my knowledge, has not been established. I think because vaping is still fairly new, even though it's been around for over 10 years, but we haven't studied people for 20 or 30 years to really establish that correlation. So more to come in the next decade or so, I believe. As in the case in lung cancer and smoking, the correlation took a very long time until scientists and pathologists and clinicians were able to make that correlation. As in the case of lung cancer and smoking, it takes decades before that risk factor kicks in and contributes to the lung cancer.
Okay. Well, going back to to asthma, you said there's different kinds. So is it just controlled, uncontrolled, or what are the kinds and what do they do?
So we classify them in more than one different way. There is one mechanistic, if you would say, classification. So what we call it atopic asthma. Atopic asthma is the one that correlates with the seasonal allergies. It correlates with eczema in some families, correlates with chronic rhinitis, or people who have a lot of runny nose related to some environmental triggers. So this class of asthma, atopic asthma, is the one that where the biological therapies are thriving. We have multiple ones. And then we have, just to simplify for the audience, I would call non-atopic asthma. And in the medical literature, described as non-Th2, as the Th2 asthma is the atopic one. So the second class of asthma is one that does not correlate to these allergic triggers, does not correlate to cats, mold, dust. It seems to be sometimes affected by smoking, secondhand smoking, some other triggers that are different. And this asthma has one biological therapy available for it when it becomes refractory and difficult to treat. The other way of classifying it is according to severity. It starts from the mild intermittent asthma. That's somebody who coughs or wheezes once in a blue moon. It happens only once every few months. They reach out to their rescue inhaler, they take 2 puffs, they go on with their day. That's mild intermittent asthma. And the next class that is above that is mild persistent asthma. That's somebody who is needing their inhaler more frequently. And then we have moderate persistent asthma and followed by severe persistent asthma. So that's a classification according to severity. And the more you go up the ladder of this classification, the more the patient is symptomatic, to the degree that some patients are symptomatic almost on daily basis. They're using the rescue inhaler every day, even though they're taking their other scheduled inhalers.
What about people that wheeze? Are there some that wheeze on inhale versus exhale only? Or if you're breathing in or out, what if it happens in the beginning of the inspiration or exhalation or at the very end? What does that tell you?
Yeah, so from a clinical standpoint, the asthma typically is a wheezing on exhalation. That's the finding we are able to auscultate or the patient would describe. So there's more air trapping on exhalation, and that's what causes the wheezing. But if it becomes like very uncontrolled or very difficult to control, especially when somebody's coming to the emergency room because they can't breathe or they can't complete a sentence, that's where we find it to be happening biphasic. It happens on inhalation and exhalation.
But does it matter if it happens in the end of the exhalation or the beginning, or does it only happen at the end?
In the clinical context, I don't really think it matters much. I think like the history of asthma, the finding of wheezing per se, ruling out similar diseases, that's what puts the clinical picture of asthma and diagnosis together and gets us to classify it.
Yeah, the reason I ask is sometimes I'll, if I have asthma, I'll wheeze, but sometimes maybe I have a touch of it and I won't wheeze until like I blow all the air out and at the bottom of the lung, which is what it feels like. Not the bottom of the lung, but the last of your air is where the wheeze is. That's why I wonder if there's a difference.
Right. That would indicate that if the wheeze is only at the very end of the exhalation, it suggests that the asthma is fairly controlled. I mean, ideally, we don't want to hear any wheezing. With a good inhalation, good exhalation, clear, that's ideal. If it's at the very end of exhalation, the way you described, that's basically, as you would say, just a touch of asthma, or it's just a little bit uncontrolled. Yeah.
Okay. And then what about, you use the inhaler, but it has like 160 puffs. Sometimes, let's say you're busy, you can't get to redo the prescription and you keep using it after it says 0. It doesn't work as well. I guess it's like driving your car down to below the before you show up, is it a bad idea? Like if are you just inhaling like accelerants at the end of the canister, or what are you doing?
Yeah, once the meter hits 0, there is no medicine in the canister. Yeah, it's just air.
It feels like there's a little bit, but then it truly does go to 0. But so it's just, I mean, essentially it's just like it's a placebo at that point. It's just doing nothing.
Right. It might give you a placebo effect, and there might be a little bit residual of medication, but it's definitely well below the dose that the patient needs. For my inhaler, I'm unable to tell if it's 0 or not. If you cover the meter, I can't tell because it doesn't have a taste. But some inhalers do have a taste, so maybe that's why some patients would be able to tell that they're still a little bit despite 0. But technically, it's once it says 0, it's telling you that the dose is no longer what you need, or it's much less than that.
Yeah. What if someone, they finish their inhaler and then they take a few days off and then they get a new inhaler? Is that going to cause them a problem? Like, should you not have any break? Is it good to take a break?
Yeah, a very good question. So it's basically an interruption in treatment. In some people, it's not that it wouldn't impact them much, especially if the asthma is well controlled, the triggers are eliminated, the acid reflux is under control. Some patients, they can go without their inhalers. It's not advisable because it can be a little bit, the longer you wait without the inhaler, the more unpredictable the asthma will be. But some patients, they go off for a few days and then they're back on the inhaler and things are back to normal. But some other patients will tell me, since I ran out of my inhaler, I can feel it coming back. So they can feel some cough, they can feel some chest tightness. And yeah, for sure.
Yeah, I felt like a few days off of it, the asthma starts to become less controlled. And then when I start a new one, the first one's always the best. It's like, feel really good,
Yeah, so that gets you back to the baseline of treatment, yes.
Okay. What about if you've been on a medication for a while and all of a sudden it just doesn't seem to be working anymore? Should you, I guess, maybe one thing to do is switch to to a different brand or a different medication mix? Or
yeah, it happens once in a while where somebody's asthmatic is taking a medication, an inhaler, for years or for some time, and all of a sudden it seems to be working less efficiently than before. Then definitely something has changed because it's the same medicine, same dose, and the patient is taking it the same way in terms of method. The method impacts medication delivery significantly sometimes. So if all of a sudden gradually the asthma is becoming uncontrolled, then there's most likely a new trigger in the environment, or there's new acid reflux, somebody's smoking around them. There's something that has changed for sure. That's something that we try to figure it out with the patient so that we can get that trigger eliminated so that we don't have to escalate therapy. Because it's always easy to escalate to a higher dose inhaler or a combination inhaler. Like we have inhalers that have 3 medicines in one. That's more of like maximum inhaler you can give because there are 3 different medication classes in it for asthma. And once we hit there, I'm personally not a big fan of escalating there without figuring out why we're escalating. So yeah, definitely we always have to check what has changed around the patient.
And I noticed like with Dulair or Advair, it's always a number / another number. So I guess to be a combination of 2 compounds. How do you know to titrate which compound and how much to give? Like what, again, in these, what are the 2 compounds that it could be, like salmeterol and flucosinate, whatever it is, and how do you know the ratio?
Yeah, so the salmeterol, a common component of combined inhalers, is the steroid component, and there's formoterol as well, and budesonide. So those usually they have a higher number. They're usually in the hundreds of micrograms. They can start anywhere from 44 all the way up to 500, depending on the brand and the manufacturer. So that's usually that component, the inhaled steroid, is the one we change the dose on. If somebody needs more, their asthma is not controlled, that's the number you will see it going up. The other smaller number, that's the long-acting beta agonist. It's a medicine that relaxes the smooth muscles of the airways and dilate them. And usually in these combination inhalers, it tends to be fixed regardless of this inhaled steroid dose going up or down. So you will see the same numbers where there's 5 or 10 micrograms. So the ratio itself is not of clinical relevance. It's the dose of the inhaled steroids that usually goes up to double for the next dose, typically, and then reassess if the patient is responding better or not.
Why twice a day is it recommended? Is it just that, like, if you put in double the steroid but only did it once a day, does it get absorbed or become ineffective according to a time curve? So that's why you want to have it twice a day to keep it at the right level?
Yeah, that's a very good question. It goes back to the half-life of the medication itself. So basically, within 12 hours, the medicine is out of the patient's system and is no longer active. So they need the second dose after that. It's like for example, in other disease, like in diabetes, for example, if somebody's needing insulin in the morning, it's going to have an effect only for a specific number of hours, and then it loses its effect. It's basically metabolized and no longer active. So they need another injection at that point. So that's the same thing for inhalers that are meant to be twice a day. They have to be taken twice a day just to make sure that 24 hours a day, the medicine is active in the system. There are some combination inhalers that are prescribed only once a day. And the reason is that they are chemically compounded in a way that they have a longer half-life and they do last 24 hours.
Okay. I guess so. The ideal protocol is what, upon waking and right before bed, or is it better to do it in the middle of the day or with food, or does it matter?
Yeah, no relationship to food, and as long as they sync 12 hours apart, usually waking up in the morning and before going to bed, that's usually would make the every 12 hours sync correctly. Because if somebody takes it sometime in the afternoon, that means they need to take the next one after midnight. And I would imagine probably for a night owl, that might work, and that would be medically appropriate in that case.
What about using a spacer versus not? The only time I've used a spacer, I guess, was like, in a hospital if I needed like a treatment, which things are really bad many, many years ago. But what does a spacer do? And is it better to always use a spacer?
Yeah, the short answer for using a spacer is to use it for vast majority of patients, unless if the asthma is well controlled for years and somebody has been on only one inhaler. I don't think there is utility of adding that. But in general, it helps most asthma patients in two different ways. Number one, it helps delivers more medicine to the alveoli, more to where it needs to be. So on average, it was studied and found that if somebody uses the inhalers without the spacer, only 10% of that puff is getting to the alveoli, to the terminal.
Oh, wow.
If you use a spacer, actually up to 25% gets delivered. So you're getting more medication delivered. And that goes back to the laminar flow. It just makes the flow of the air as you inhale it more laminar or more straight. So it hits it gets all the way to the target easier with more success. So that's reason number one. Reason number two, we give a spacer to our patients is that it reduces oral thrush, especially in the pharynx, in the back of the mouth. And again, with inhaled steroids, part of that medicine is being deposited in the mouth and the pharynx, down around the voice box. It gets deposited everywhere because it's swirling around as it goes down into the lungs. But with a spacer, it will be more straight and less likely to deposit in these areas and less likely to create this local side effect of candida or thrush.
Wow. So it reduces the potential medicine delivery by 90%.
It increases medicine delivery from 10 to 25. Yeah.
Oh, 25, sorry. Yeah. That's crazy.
25. Yeah. So still 25 is not
2.5 times. Yeah.
Yeah. 2.5 times. 25% is usually reasonable. Like it should get the patient under control. If not, we increase the dose, or we're not going to be too optimistic to get close to 100%. We are accepting that a big part of the medicine is going to get lost along the way just because of the physics.
Any types of spacers that work better than others, or doesn't matter? Same thing?
Not to my knowledge. There are definitely different types, but they all do the same thing. Yeah.
Okay. Is there any way to build up your lung reserve? I've seen like advertised on Amazon, like these looks like a little like a plastic pipe has got holes in it, and you could make the holes smaller or bigger, so it's harder to suck in or blow out. And legend has it, if you use this thing every day, a couple times a day, then it'll strengthen your lungs. Like, is that true? And what are you strengthening? And what are your recommendations there?
Yeah, there's evolving evidence about this device you described, and it comes in different names and from different manufacturers. One that I'm not endorsing, but I'm very familiar with, is the Power Breathe. And this device basically works by training the diaphragm. The diaphragm is a muscle, just like any other muscle, can be trained and strengthened, and it can become weak with disease for a lot of different disease processes. One of them is being COVID. So what this device is supposed to do is, just like you're exercising your biceps in the gym or lifting weights, it's the same thing. It's resistance intense exercise to the diaphragm makes it difficult to take a deep breath, and then you grade it. So for example, you would do 10 breaths in the morning, 10 in the afternoon, 10 in the evening, and the next week you increase the resistance on the device and you go to the next level. And the device itself comes in different levels as well. So there's low, intermediate, and high, if I'm not mistaken. So once you graduate from one, you can go to the next one. It definitely benefits people who have already lost significant diaphragm strength, typically coming out of a prolonged ICU admission, for example, after they've been on the ventilator for some time. This is definitely a population that would see more benefit from it. For somebody who is like fit and healthy, I don't think it might not add a significant amount, but maybe a little bit. I would say maybe 10 to 20% can be gained. And the reason I'm adding that is anecdotally, we can see that patients who play wind instruments or windpipes, they're actually in the PFT lab, they have lungs that seem to have definitely higher capacity and more strength compared to counterparts of the same age and height. So definitely you can get the diaphragm stronger to what it is at baseline. But for people who lose some of their diaphragm strength, they can regain a significant amount back with these specific exercises and devices for sure.
Oh, one thing I forgot to ask about the inhalers. When you inhale, I guess you're supposed to hold your breath for a little bit of time. It's funny, even when I watch someone in the movies use an inhaler, I instinctively hold my breath as if I'm using it. It's weird. Or if I see other people using it, I hold my breath for a sec. Are you supposed to? And how long? What happens if you do too much, too little?
Yeah, ideally 5 to 6 seconds. They used to say 10 seconds. I think there used to be more of an anecdotal recommendation. The idea is to maximize medication delivery. As you would expect, if you inhale for a second or two and exhale, probably some of the medicine is not going to get to where it needs, especially like the bases of the lungs, the periphery. So the argument is that I want to take a very deep breath, hold it, make sure that the distant alveoli, the smaller airways, the medicine is depositing and kicking in, before you exhale. Because if you exhale too rapidly, in theory, the medicine is not being optimized.
Okay. So that plus the spacer, you can get a much more optimal delivery than you otherwise would.
That is correct.
Okay, that makes sense. Any other, activities or strange things that could trigger asthma? Like, I guess it's exercise-induced, cold air-induced. I don't know what other inducements there are. Cats and dogs, obviously, dander, maybe chemical pollutants. Are there any other, things that people do or don't do that hurts their ability to deal with their asthma?
Yeah, so mold is a big one. Like sometimes, can be difficult to identify. Like sometimes it might not even be visible. So I've suggested a mold inspection when we're not finding anything and the patient's having a classic asthma that is difficult to treat, but there's like a suspicion. Like for example, like they've had water flood in the basement, for example. That's very high. That's a pointer that there's some mold there already. And if they're going into the basement like frequently for something or they spend some time there, that's going to make the asthma difficult to control in a lot of people. Another big one would be pollens in spring, lawn, flowers, certain plants, indoor, outdoor, that also can be a known asthma trigger that can also be more difficult to control because these seasonal triggers are everywhere. One way to mitigate it is a HEPA filter inside the house, especially in the bedroom. If you just leave them running throughout the season, that can minimize asthma exacerbation and improve its control. There has been studies that supported HEPA filters, especially in children. So that's another way to mitigate asthma triggers. Other triggers, work exacerbated asthma is another type of asthma, or work exacerbated or work related asthma, and where patients notice that when they come back from work, their asthma is at its worst, or during the shift. And usually it's could be a fume or a dust or some irritant at their job. Another clue is that they improve on the weekends or when they are out of the, on vacation. And there are tools to assess that better, where you can give them a handheld, device to measure their flow, a peak flow meter, and you have them to record their numbers, how much they can exhale on that peak flow meter. It gives you a number that it's supposed to match your age and height and sex, where, for example, my ideal number is around 450. That's ideal. If I blow and it's telling me 300, definitely something is going on, even though I might not be able to tell that I'm having symptoms yet or my symptoms are minimal. So tracking these numbers before attending to the job job and during the job and after and on the weekends can make that correlation that something is in the work environment that is driving the asthma.
What happens to long-term asthmatics that they reach older age, 70s, 80s, even 60s? Do they tend to have more problems as they age, or they can age well with it?
Yeah, if they get the right inhalers, right dosage, they can live a relatively normal life expectancy. If the asthma has been difficult to control for a long periods of time, they haven't been, they had some interruptions in their inhalers, they had a lot of exacerbations, they can definitely lose lung function, and that would look like somebody who has COPD, a disease that happens from smoking. So what we call fixed obstruction, meaning that their airways are so tight, even when you give them a medicine in the pulmonary function lab, the lungs do not restore their function to the baseline. So they have like a fixed part of the disease. While in most cases of asthma, especially in younger adults or early life, it should be fully reversible in most cases, where you give them the medicine in the lab, you remeasure their lung function, and it looks normal. So if somebody ages with uncontrolled asthma, they can have fixed obstruction, they can have chronic symptoms, they will probably be more fatigued. Yeah.
Okay. Anything new in the world of asthma that's coming or here clinically, or that's getting close to coming, that'll be a breakthrough?
Yeah, the biological therapies definitely made a big difference in the last few years. We had omalizumab first that came out, if I'm not mistaken, from the 1990s, and it remained the only biological therapy available for asthma for a long time, until the 2010s, when we had multiple biological therapies that came out. And basically, biological therapy is a treatment where it targets specifically a step in asthma disease process, and making the asthma cycle, if you would say, or the chain of events that leads to asthma disease. It interrupts that chain by hitting one or more steps in that process. So these medications, they're administered either under the skin or through an IV infusion. The ones under the skin can be self-injected by the patient. In many cases at home, they just need to be trained of how to use it, and typically they only are needed like on average either once a month or once every 2 weeks, so they're not too frequent. They are not a substitute for inhalers, but definitely for patients who are not controlled on maximum inhaler therapy, then we start discussing biological therapy, and typically it improves their asthma significantly. You would see somebody who is showing up to the emergency department every few weeks, even though they're taking their inhalers, but their asthma is so difficult to control. You give them on a biological therapy, and all of a sudden they're no longer coming back to the emergency. I mean, they come back, but it's much less frequent, and the studies have shown less readmissions to the hospital, less use of oral prednisone. That's the rescue pill steroid that we need to use when the asthma flares up and the inhalers are not working. And as you would imagine, prednisone or other oral steroids, repeated courses through the year or through the patient's life, definitely puts them at a high chance of developing long-term side effects from steroids. So that's another area that biologics have helped significantly, is reducing the need for oral steroids for patients.
Are there any inhalable exosomes that can target the lung cells and either do maybe some gene therapy or work better than current inhalers? Anything like that in the works?
Nothing in the pipeline that is that I am aware of that is going to make it to the clinical world. There's definitely a lot of research going on gene therapy for a lot of different chronic diseases, but I'm not familiar with that research specifically. For targeted treatments that are inhaled, in the world of asthma, we still don't have a targeted, specific like a biologic inhaled. All the biologics are parenteral, so they're injected either under the skin or through the IV.
Well, we're going to talk about this. What's the method of action of typical inhalers? You said part is beta agonist. So what is that? And what are the other parts, and how do they help asthma?
Right. So the beta agonist class, which comes in short acting and long acting, the short acting is typically the rescue inhaler. They go and bind to the beta receptor, which is on the smooth muscle of the airways or the bronchi, and cause them to dilate or relax in other ways. So that's the mechanism of action of these inhalers, and they only work for typically somewhere around a couple of hours. And if the asthma is still flaring, if the trigger is still there, the smooth muscles are going to start to constrict again. So typically the person needs more beta agonist in that case or other treatment. So that's the beta agonist part. It relates to a receptor on the smooth muscle. We have a muscarinic receptor medications. So They come also in short and long term, and also they participate in smooth muscle dilation, and they also reduce secretions. So there's a lot of sputum production or phlegm production with the asthma. They help with that component too, although the presence of phlegm is not necessary to prescribe these medications. Other medications are the inhaled steroids, which reduce inflammation locally in the airways and the smooth muscle and throughout the respiratory tract, and the other much less used inhalers that have other mechanisms as well.
Okay, well, very good. So, Aahd, where do you help people? Like, where can you? What's the zone of your practice? Where are you located, and how far away can you help people? Do you do any telemedicine, or is it not needed?
Yes, my clinic is at the University of Minnesota in Minneapolis, and I also do a limited virtual clinic for anybody who is part of the University of Minnesota system can be seen by me, or if they're across the state line in Wisconsin, as I still have my license active there. But definitely it has to be through the University of Minnesota system. That's my only employer currently. And also I see patients in the inpatient setting with the hospitals affiliated with the University of Minnesota Medical Center. And happy to, if anybody needs help in the areas I can serve, I'm more than happy to.
Okay, well, very good. Well, thank you so much for coming on the podcast. I appreciate it.
Thank you very much. Thank you.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.